a few ways of doing ultrasound shoulder when Anik and one of your other colleagues was there. So you may have some idea, but not a lot. I completely understand. So both of these techniques are complementary. So you will get information from the ultrasound and you will get some information from MR. The only difference is that ultrasound will not tell you what's going on with the cartilage and the labrum inside the joint, whilst the MR will tell you. Also, the marrow, you won't be able to get any idea as to what's going on with the marrow unless you do an MR scan. And lastly, the muscles. You may be able to see the muscles on ultrasound, but you actually can't figure out if there is fatty infiltration of the muscles. So that's major difference between ultrasound and MR. So if somebody asks you which one would you rather do, most of the shoulder pain comes from rotator cuff. So if you were to answer that you would do a shoulder ultrasound, that's entirely reasonable. The only thing is, can you actually do an ultrasound of the shoulder? So it's very, very operator dependent. So unless you actually have some experience, it may be difficult. Whilst MR is like any other modality, which if once you know the anatomy, you'd be able to actually quite easily pick up the pathology. So the role of imaging in shoulder primarily is basically, number one, to assess the rotator cuff, which is all these four tendons, to assess the labrum, especially if the shoulder is unstable. So, of course, these are the two important things. Now, there are two important things that clinically patient present with. One is impingement clinically, and the other is instability clinically. So how do you diagnose them? Impingement is a clinical diagnosis. Instability is also a clinical diagnosis, but there are underlying causes, structural things that you can pick up on imaging. And of course, we do in our settings, we always do X-rays, we do ultrasound, we do MR, we do CT. CT, again, is a niche thing that you would specifically require if you are suspecting a fracture or a bony Bankart's lesion. Sometimes we do CT arthrograms, which are in post-operative patients because there's lots of metal work. So that produces less artifact on CT arthrogram compared to an MR arthrogram. But it doesn't matter if you've got a reasonably good MR machine, which I know you don't have at BMC because you have something like point something permanent magnet, which doesn't give you that good a quality. But most of the departments in UK have actually most of them have 1.5 and 3 together. So in every department, this is the combination. How many depends on the extent of the referral center. So, for example, we have about 8 or 10 MR scans, but in a normal DGH, there would be at least 2, if not more, MR scans, and the combination is usually 1.5 and 3 Tesla. So, what are the sequences? This is the important bit. What sequences you should be doing? Number one, you should be doing imaging in all 3 planes. So, and by the way, Aisha, please, if somebody wants to stop or ask questions, it's an informal session. I'm more than happy to, answer questions as we go along because it becomes very difficult to remember everything. So as we go along, if somebody has a question, just raise your hand and, we can always ask questions.
Sure.
So the sequences that we should do, ideally, in all 3 planes, do coronal in 2 planes. Do coronal plane sequence in 2 different sequences in a coronal plane. So in other words, we tend to do T1 and a PD fat sat. We then do a sagittal fat sat PD and an axial PD fat sat. In other words, PD fat sat, proton density fat suppressed sequence, is your main bulk horse. That's the one that you should do in all 3 planes. So that's given. And then you should have 1 extra coronal or sagittal T1 weighted sequence. And I'll tell you why it's important, because T1 is important to assess the muscle atrophy. So I don't know how many of you were there when I was doing this talk when I was when we were in Quetta last month. But you should have at least 1 T1 weighted sequence. It doesn't matter which plane. You can decide yourself. Now, most of these machines tend to do dual echo. In other words, with the same amount of time, you can get a PD and a T2 weighted fat-sat sequence. So in the same sequence, you can get two sequences, same time. So if you can do a dual echo, which is a coronal
recording in progress,
which is a coronal T2 and a PD, that gives you an extra advantage in the same time. So this sequence shouldn't take you more than 20 minutes on a reasonably good machine, maybe 25, but not more than that. So it's quite straightforward to do these sequences. So remember, this is what you need to have in your protocol. In terms of arthrogram, I think you guys are not doing arthrograms, so there's no point in talking too much about arthrograms. But if somebody asks you in the exam, say, if you have you ever done one, just say so you haven't done one. But if you have, then if you're injecting gadolinium-based contrast agents, use T1 fat suppressed sequences. If you're injecting saline, then you do a PD fat suppressed sequence or a T2 sequence just to give the same effect. So you can get the same effect from both of these. It doesn't matter. Okay, so let's look at let's look at an MR scan, and let me show you how I look at an MR scan. So Aisha, what can you see on the screen? Can you still see the PowerPoint presentation or my example case?
Sir, I'm able to see the PowerPoint presentation with this slide saying shoulder stability.
Okay, what can you see now?
Case.
Okay, good. So now we've gotten, what you can see is an axial sequence through the shoulder. Is that correct?
Sir. Yes, sir, it's an axial sequence.
So you can see. So what I tend to do is I normally start by looking at the axial PD fat suppressed sequence. And why do I do that? Number of reasons. Number one, as we scroll through, the first thing it tells me is what is the glenohumeral orientation. So is there any subluxation? Is there any dislocation? So straight away you can look at this sequence and tell in your mind. Now remember, I'm just telling you how I look at it. You can decide whichever way you want to look at it. But the reason is whichever way you want to look at it, the important thing is to keep following that that sequence so that you don't miss things. So keep looking at things in the same order. So every time you look at a shoulder, try to have the same sequence. So in other words, you look at the same things, and then chances are that you won't miss things. So the first thing is look at the glenohumeral orientation. No subluxation, no dislocation. This is also a very good sequence to look at the articular cartilage, which is this gray structure. Can you see my arrow moving, Asha?
Yes, sir.
Okay, so the cartilage is sort of gray, the fluid is bright signal, the cortex is black signal, and the marrow is gray signal. So that's the kind of thing that you're looking at. So you look at the marrow, you look at, remember, PD is not that good for looking at marrow. T2 is better, STIR is better for looking at marrow. PD, if there is marrow edema, it'll sort of undercall it. So that's why, remember I said if you've got a dual echo, in other words, if you've got a T2 fat suppressed sequence in addition to a PD, then the marrow edema will light up. So I tend to have a quick look at the articulation. I tend to have a quick look at the articular cartilage, both at the glenoid and the humeral head. This also tells me about the morphology of the humeral head. In other words, is it round? Is it flattened anywhere? Are there any small subcortical cysts, as we would normally see quite frequently at the lesser and greater tuberosities? So that gives me an idea about the shape. And why I'm worried about the shape, because if somebody's dislocated the shoulder, you may have a Hill-Sachs defect, you may have a reverse Hill-Sachs defect, you may have a little bit of flattening. Now, normally the humeral head is round, except where it goes below the level of the coracoid, you may have a little bit of flattening at the back. So that's entirely normal. So if you were to call somebody a Hill-Sachs defect, you have to be at the level of the coracoid or close to it. So if you look on this sequence, this is the coracoid process tip. You look at the head of the humerus, it's quite round. But if it was flattened here, then that would suggest that the patient may have had an anterior dislocation, and this is a reverse Hill-Sachs. Sorry, this is a Hill-Sachs defect. Now remember, the Hill-Sachs is quite at the top of the humeral head. The reverse Hill-Sachs, which is the opposite flattening, which tends to occur in posterior dislocation, can occur anywhere. It can occur at the top, it can occur at the bottom. So that rule only applies for the posterior. The normal Hill-Sachs defect would be right high up here. There's no such thing as normal Hill-Sachs, but a Hill-Sachs defect. So that's one thing I look at just right at the start. The second thing I look at is the labrum. Now, the labrum is this triangular structure. It's sort of, imagine the meniscus in the knee. It's a triangular black structure, and you want to see if there are black triangles at the front and the back. And you always start at the top, where you should see, you can almost see the continuity of the labrum, because remember, it's the same labrum that goes from front to back. So you start looking at the labrum to see what sort of signal is there. Is this black, which is great. If there is bright signal coming in here, for example, then you start thinking about, has there been a tear? Is there degeneration? Is there a paralabral cyst? So same sort of things that you look at, the hip, the knee, the shoulder is the same thing. So if somebody's got a labral tear in the knee, or a meniscal tear, which is the equivalent what you sometimes get, you get parameniscal cyst. It's the same thing here. So if you have a tear of the labrum, you may actually end up having a cyst. So if you look carefully, can you see there is a bright cyst here? Now, this bright cyst is not the same as this, because this cyst stops here, whilst this is something different. We'll come to it in a second. So this immediately I can have a look at the anterior superior labrum. I know there is a problem and there is a cyst, which means this can mimic what? This can mimic rotator cuff symptoms. In other words, if somebody's got a supraspinatus problem or an anterior superior labral problem, they'll present clinically the same way. So that's why it's important for you to know what is causing what. But they can present clinically the same way. So you can see a cyst coming here. So that's the labral cyst. Okay, so you keep looking at the back. Now, if you look at the posterior part, this labrum also does not look normal in this particular case, but I would normally look at it because it should have been a nice black triangle. All you see is a sort of a tiny black dot in the middle, which means there may well be a previous instability in this shoulder, and the labrum may well be degenerate, may well be abnormal. So you keep going down, make sure that you keep looking at these labral contours all the way down. So this is the anterior inferior labrum, which looks what it should be like. This is the more posterior inferior glenoid labrum, which looks pretty much what it should like. So this is right at the bottom. Now, whilst I'm looking at this, I'm also, now I know I'm at the bottom of the joint, I would start looking at the joint capsule, because remember, this is where you see the bottom of the joint capsule. We look at this capsule in the coronal as well, and the sagittal, but this is how you look at that. This is the bottom bit of the joint capsule, and this is important because remember, patients with adhesive capsulitis will have edema and thickening of the joint capsule, as you see here. So if you look at the capsule, it's quite thick, isn't it? And it's sort of edematous or bright. It should normally be sort of gray or low signal rather than being intermediate or bright signal. So already I know that without looking at any other sequence, all I've done is just looked at the axial sequence, and I know that there is something going on in the chat in the background. I better make sure I have a look at it. Okay, so nothing. No, hang on. Aisha, can you just point me if somebody raises a question, because I'm more looking at my slide. So if you see a question coming up, just let me know.
I will let you know, sir. Don't worry.
So already I've noticed that this patient has got a labral tear anterior superiorly. He's got a paralabral cyst at the front. He's got an abnormal posterior labrum. I've also already noted that this patient has got edema and thickening of the inferior joint capsule, which means adhesive capsulitis. So without looking at any other sequence, we've already come to a conclusion, at least this much is going on. We look at all the other things in a second. Now, what else can I look at when I'm looking at the axial sequence? This, we've looked at the joint itself. Of course, I look at the glenohumeral joint effusion on this. There's no effusion in this case. This much amount of fluid is entirely normal. You're allowed to have a little bit of fluid in the inferior axillary recess as well. So if you see a little bit of fluid here, that's entirely normal. So we then look at the structures outside the the glenohumeral joint. What are the structures? Now, we look at the soft tissues around it. So the soft tissues around it, of course, are the muscles. So that's the infraspinatus muscle and the infraspinatus tendon. Remember, the tendon starts in the middle and it inserts onto the posterior part of the greater tuberosity. So you can immediately see the infraspinatus tendon very nicely on this to see if there's any abnormal signal, any partial or full thickness tears. At least you get an idea. So you see a little bit of high signal right close to its insertion. Normally the tendon should be black all the way to its insertion. So that's one thing I've noticed. Then you look at the front and you see the same thing for the subscapularis. So you can see the muscle here and you can see the tendon in the middle and it inserts nicely onto the lesser tuberosity anteriorly, and where it inserts, you can see a little bit of accretional change with some cyst. This fluid that you see centered around the subscapularis tendon is actually in the subscapular recess. So there is a little recess which surrounds, or a little sort of bursa which surrounds the subscapularis. And this is called the subscapular recess. So if you see, this is more than what we expect. We see just a trace of fluid, or sometimes we don't see anything. So if you see this much amount of fluid, this is abnormal, because this is fluid more than what we expect. So again, I've looked at this tendon. So I've looked at the two tendons. Then the third tendon I'd look at is the long-headed biceps tendon. Remember, this tendon is both an intra and extra-articular tendon. In other words, it starts inside the joint. So if you look at this tendon, let's follow it, see where it goes. We are coming up now. Keep looking at this tendon. So what will happen is it'll change its direction as it enters this is the bottom, and now we're coming up, and it's going to change the direction and become horizontal. And when it becomes horizontal, you just see a ghost shadow. That's all you'll see, a little ghost of the tendon. Because remember, this tendon is almost, you're cutting in the same plane. You're in the same plane as the tendon. And this tendon arises from the anterior superior margin of the glenoid. So it runs at this angle, almost obliquely. And then when it reaches the top of the groove, it dips down. So you actually follow this tendon beautifully, and you can see it all the way. So again, I can see that this tendon is normal and is located within the groove with no obvious subluxation or dislocation. There's a little bit of fluid around it, which is fine, slightly more than what I would expect. You're allowed to have a little bit of fluid at the back of the tendon, not all the way around. If you see fluid all the way around, it generally means there's a little bit of inflammation of the tendon sheath. So on the axial, we've then assessed the three tendons. Now, the fourth tendon is the supraspinatus tendon, which is running right here. So right at the top, you'll see the supraspinatus muscle and the supraspinatus tendon. If you see high signal here, that's where it inserts onto the tuberosity. So this will give you an idea that there may well be a tear if you see bright signal. In this case, I don't see any signal change. So I think the supraspinatus looks okay on the axial. But at least we've looked at now all the important tendons of the shoulder on the axial. At the same time, I'm looking at the muscles as well. So if you look at the muscle, they're pretty much the same signal everywhere. So the same sort of gray signal. And why it's important, sometimes you can get edema of the muscles, which is what we sometimes get in neurogenic muscle edema. If somebody's got fat change or fatty replacement, it may be difficult to pick up on this sequence. So that's why we've got the T1, which we'll come to later. So on the axial, we've then looked at So we first looked at the glenohumeral joint, we've looked at the cartilage, we looked at the marrow, we looked at the labrum, we looked at the joint capsule, we looked for the joint effusion, we looked at the shape of the humerus, the humeral head, and then we went outside, we looked at the tendons, both the infraspinatus, the subscapularis, the biceps tendon, both the extra-articular course and the intra-articular course, and then we followed it all the way to the top where you see the supraspinatus muscle. Now, what else can you look at on the axial? You keep going further up from the supraspinatus, and you'll see the AC joint. Now, AC joint is best assessed on almost all the other sequences except this one. So coronal is better, sagittal is better, but the only advantage of axial over the other two sequences is something called an os acromiale. So if somebody's got a triangular extra ossicle, you'll only see it on this particular sequence. And this is where you see it as a triangle, large bone sitting as an extra ossicle. And the importance of noting that is that it is one of the causes of impingement. So if you see a big os acromiale, don't ignore it. You have to mention it in your report because it may well be causing impingement because it is usually unstable and it causes the joint to be unstable, and it keeps pressing on the underlying bursa, and that causes impingement. So again, you can assess the AC joint to a certain degree, primarily to exclude an os acromiale. Okay, so you can see the lateral end of the clavicle here. I can tell you even now, without looking at the sequence, there are degenerative changes at the lateral end of the clavicle. There is subcortical cystic change. There is marrow edema. There's a bit of edema of the joint capsule. Remember, this is the joint capsule, the acromioclavicular joint capsule. And then you start see the acromion, and you can see there's marrow change there as well. So there are changes on both sides of the joint, which means the joint is definitely degenerate. There's a bit of capsular edema. So you can assess the joint to a certain degree. Of course, you are then looking at all the other muscles. So for example, the deltoid, you can see very nicely. And if you go towards the top, you would be able to see the trapezius muscle very nicely. And of course, when you come further down, so you look at the axilla, sometimes you'll end up picking up lymph nodes in the axilla. You look at the axillary vessels, you may remember the pectoralis major muscle comes here, the pectoralis minor, subclavius, they're all sitting at the front. You may be actually able to see if there is a tear of the pectoralis major. Most of the tears, we tend to do a large field of view, and because usually it's clinically evident that somebody's got a pectoralis major tear, they would say on the form, we are suspecting a pec major tear. So then we remember this is a small field of view. This is all centered around the shoulder. So you can easily miss things further up here. So that's why if somebody is suspected to have a pec major, we tend to be doing a larger field of view, not a small field of view imaging. Of course, you must always look at the ribs, make sure there's no obvious marrow edema, fracture, part of the lungs that you can see. You sometimes may be able to pick up things in there. Okay, so on an axial, you've pretty much diagnosed what's going on this particular patient already. So you can see how much information you can get just by looking at one sequence. And we haven't even gone to the other sequences yet. So these are the things I want you to remember in your mind. And when we look at these cases again, we'll look at these in the same order so that you pick up things. Any questions on the axial sequence?
I have been checking the chat. There was no question till now, but
okay. So
hopefully there is one. I'll let you know.
Yeah. So let's go on to now the next sequence that I would normally look at. So the next sequence that I would look at is the coronal sequence. Now, this can be the coronal T2 fat suppressed. This can be the coronal this could be the coronal PD fat suppressed, or this could be the coronal STIR sequence. STIR and T2 fat suppressed will give you a sort of a similar pattern or a similar appearance. So what are we going to do now? So we are going to now look at the important things. So of course, you will look at the glenohumeral alignment, which we already know is pretty good. We already know the cartilage is good. But what you see is a little bit of fluid in the inferior axillary recess again, which is normal. Can you see the same edema of the inferior joint capsule, which is abnormal because this patient has got adhesive capsulitis? So if I see that, that's good enough for me to say that the patient has adhesive capsulitis, although I don't have to say it because adhesive capsulitis is a clinical diagnosis, but I would always mention it in my report if I see it. The marrow, this is a very good sequence. This particular one is a STIR sequence, but if it was a T2 fat sat, this would be a nice sequence to look at the marrow. So you can see the marrow looks pretty unremarkable. There's a tiny bit of high signal, which means nothing. The marrow is generally pretty good. So what we then do, we use this sequence primarily for the rotator cuff tendons. In other words, the supraspinatus tendon, which is the main tendon which gets affected. So if you look at the supraspinatus fossa, you'll see the big muscle belly with the tendon coming in, and it inserts all the way to the tuberosity. Now, you must always look at this. This tendon is about 2.5 centimeters front to back. So that's quite a big tendon. It's like a big band which comes across. So you must make sure that you look at the tendon from the front all the way to the back, because sometimes you may have tear at the front, sometimes you may have tear at the central slip, sometimes you may have a tear at the junction of the supra and infraspinatus at the back. So that's why you need to look at that. So how do we know this is the front? Your landmark here is the coracoid. So if you find the coracoid process, you know you're at the front of the joint. This is the same fluid that we were looking around, because remember, this is the subscapularis tendon. This is fluid in the subscapularis bursa. As I go further forward, this is the tendon, the subscapularis tendon inserting. This is the same fluid. Now I'm going to start going back. As I go back, what I'll see is, first I'll see a little bit of space where there's no tendon, because that's the rotator cuff interval. Then I'll see the longer biceps tendon, which actually runs in the rotator cuff interval. If you remember the anatomy, it comes out from within the joint where it is attaching to the superior glenoid, and it runs between the subscapularis, which is more at the front, and the supraspinatus, and then it comes out into the groove and then heads down into the arm. And this was the fluid that we were looking at when we were looking at the axial sequence. So I then go further back, and now I will start seeing the supraspinatus tendon. Now, this is right at the front of the supraspinatus tendon. So you would just want to make sure that you look at the tendon all the way from front to back. So we'll keep going back now. This is sort of middle of the supraspinatus. This is the muscle tendon junction. You can see a little bit of edema of the muscle tendon junction. This is where you actually see the entire tendon and where it attaches to the tuberosity. This is called the foot plate. You can see a little bit of gray signal, not bright signal. I'm not too worried about it, because remember, as it attaches, it sort of curves and attaches onto the tuberosity. So you may have a little bit of signal alteration, but what you're essentially looking for are the margins. Look at the black margin at the top here. It's nice and smooth with no bright signal change, no irregularity. Same as the articular surface. Now remember, this is the articular surface of the tendon. This is the bursal surface, or the non-articular surface. In between here and here, so in other words, if I was to annotate, well, so in between, it doesn't let me. So in between here and here is the foot plate. This is called the foot plate. On imaging, in other words, on your MR scan. So this foot plate is important because you can get tears of the foot plate that you won't be able to see. You will reason for that is they're looking here whilst we're looking here. So this foot plate is important. So if somebody's got a foot plate tear, it's called, usually it's a partial thickness tear, and it's called a PASTA lesion, which is partial thickness articular surface supraspinatus tear, or a PASTA. And it's also called a Rembrandt tear. So make sure that you look, but it should be the same signal as fluid elsewhere. So if you see bright area, which is the same signal as fluid, then it's a tear. If you see this sort of gray area, ignore it. So we keep going back. Now we've sort of come to an area which is intermediate signal intensity. This is an important point, because this is not a tear that you're looking at. This is where the supraspinatus and infraspinatus tendon come together. The supraspinatus is finishing, and then infraspinatus is starting. So this area is called decussation point, where the two fibers come together. And where the two fibers come together, you may get a bit of brightness. Not the same signal as fluid, which is this signal, just a little bit of bright signal. Again, if you see that, that's quite normal. So you don't call it a tear. And you keep going further back. Here we're coming forward. So I'm going to start again and go back, 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 back. Now we are going to hit the infraspinatus. There comes the infraspinatus tendon. This is the infraspinatus tendon. Keep going back, and this is the infraspinatus insertion. And this is the infraspinatus muscle, and this is the tendon starting in the middle, and then it inserts. Remember, it's coming at an angle towards you, so you won't see it in one plane. So you have to slide forwards and backwards in order to see the tendon in its entirety. So this is where the infraspinatus insertion is inserting. And you can see there's a little bit of edema of the muscle tendon junction here at the back, which is absolutely fine. When we do the sagittal, we can look at these things. So on the, what I've done initially is just to look So that's one thing that we've done. The second thing is, whilst we're looking at the tendons, remember I told you the long header biceps tendon, as it goes into the joint, this point where it attaches to the labrum is called the biceps labral anchor, because remember, they have a combined attachment. The anterior superior labrum and the biceps tendon here have one attachment at the superior labrum. So you just make sure that you look at this area carefully, because all the slap tears, I'm sure you've heard of the slap, which is superior labral anterior to posterior tears, tend to occur around this area. So you look at the high signal here. This was the high signal that we saw when we were looking at the axial sequences. Remember, I told you that there was a paralabral cyst that I could see. It is the same cyst that you're looking at the front here. So whenever you see a cyst at the front adjacent to the labrum, you should be worried that there's an underlying labral tear. Whether you see it or not see it is a different matter. But the point is, you should be suspicious that there is a tear. So we go further back, and what you see here is that there is bright signal here, but this seems to be heading towards the back. Now, normally most of the slap tear, can you see a nice triangle here? This is the labrum, which is going from front to back. So this is the superior labrum. We are sort of in the middle of that labrum. We are neither at the front nor at the back, because if it was at the front, we know this is the front because we know there's a labral cyst. And we go further back. If you see bright signal heading backwards, then that's a normal thing or a normal variant called the sublabral recess. But if you signal heading away in this direction, then that is a slap tear. And the most common type of slap tear is a type 2 slap tear. So if you see, in other words, basic rule, if you see brightness heading away from the joint, call it a slap tear. If you see heading towards the glenoid, ignore it as a normal variant. So in this particular case, although this is heading towards the back, I would still be suspicious that there's an underlying tear that we are probably not looking at or not picking up on these non-arthrographic MR sequences. If we were to do an arthrogram, we may actually see a tear extending into the anterior superior labrum. So I always look at this area as well. Okay, so that I just need to mention it along with the tendons, because remember, the biceps labral complex is actually part of the biceps tendon attaching. So on the coronal, we've looked at this. Now, the third thing that I want to look at whilst we're looking at the coronal is actually the AC joint. Now here, what you see is the same thing that we've already picked up on the axial, that there is wear and tear change. There's a little bit of marrow edema of the lateral end of the clavicle. There's a bit of edema of the joint capsule, and there's a bit of marrow edema of the acromion. Now, this is an important sequence because it tells us a couple of things. First of all, it tells us that the orientation, the AC joint is aligned. In other words, there is no superior subluxation of the acromion or the clavicle in relation to each other, one. The second thing, it tells you that there is no diastasis. In other words, the AC joint space is well preserved. And the third thing it tells you is what's going on the undersurface of the AC joint. There may be an osteophyte sitting here, which is pressing on the tendon. So you actually may see a little indentation, especially if the joint is quite worn out or degenerate. And the fourth thing it tells us is what is the shape of the acromion on the coronal sequence. Now, you may have read the classification of the shape of the acromion, but that you've usually seen on the sagittal, right? On the lateral X-ray as to whether it's hook-shaped or flat or is it convex. But actually, this is also important on the coronal sequence, because here what you see is a sort of a horizontal, maybe just a tiny bit of lateral slope. But if you see the acromion to be heading in this direction, that means that the acromion has a significant lateral impingement. So when you report, whenever I mention, I'll tell you what I say in my report. But whenever I mention a point, I always talk about the morphology of the acromion, both on the sagittal and the coronal sequences. So I will tell them how it looks on the sagittal, but at the same sentence, I'll mention how it looks on the coronal. If there is a coronal slope, I would mention it. So that's why, but it's important that you look at it. Okay, so we've now looked at the tendons, we've looked at the biceps labral anchor, we've looked at the AC joint. Of course, we want to look at the muscles whilst we are here, because if there is any edema of the muscles, sometimes you remember, what is this muscle? This is the teres. minor. Remember, the teres minor muscle is the one which is under the infraspinatus, and then you've got the teres major. And the infraspinatus is the bigger muscle, which is triangular. So the infraspinatus is triangular, whilst the teres minor is more oriented longitudinally. So in other words, rectangular. So it's more rectangular muscle. Hardly ever worry about teres minor. The only thing I would worry about teres minor is if you see edema of the muscle or fat atrophy, which means the axillary nerve is involved, because remember, the axillary nerve runs in this little space here. You've got the triangular and the quadrilateral spaces on the inferior part of the glenohumeral joint where the posterior circumflex humeral artery and the axillary nerve run. So if the nerve gets impinged, then the muscles which get affected are the teres minor and the deltoid. And of course, the supraspinatus and the infraspinatus. So that's the only significance. Otherwise, we tend not to worry too much about it. And of course, you've looked at the muscles and you've looked at the joint capsule, which I said right at the start. So the coronal gives you a good overview of what's going on with the rotator cuff tendons. Any questions on the coronal, PD or T2 or STIR? So remember, I know there's a lot of information for you to remember, but if in your mind...
Recording stopped.
When we go through these sequences again, we look at these, you'll remember some of these things. Even if you remember half of these things, that's
recording in progress.
Okay, so if there are no questions on the coronal, then what is the third sequence I would look at? The third sequence I would look at is the sagittal. Now, this is a sagittal PD or a T2 fat sag. Most of the departments do a PD. And this is what we would do as well, although in this particular case, it's a T2, probably because it's a dual echo, it doesn't matter. So what I want to look at here is there's the same things pretty much things that I looked at on the other sequences. But this particular sequence is really good to look at.
Recording in progress.
In a second. So normally if it's flat, it's T1. If it's sort of hook-shaped, pointing downwards, it becomes T2. These are the two important ones that you should remember. The one which has a hook can cause impingement. So that's one thing. Can you see this black structure here? See this structure, this linear black structure? This is the coracoacromial ligament. This is the band-like ligament which is responsible for impingement. So if you get thickening of this ligament, people get impingement. When surgeons go in and do subacromial decompression that you might have heard of, then they cut away this ligament. So this ligament is actually taken away because this is responsible for impingement. And if you follow this ligament, see where it's going. It's heading towards the coracoid. So if you look at this black thing here, if you follow the black thing all the way back, see where it goes. It attaches to the undersurface of the acromion. So it's the coracoacromial ligament. So that's one thing I look at. So I look at the AC joint, I look at the coracoacromial ligament, and then I keep going and I look at this area. This is the coracoclavicular ligament. Now remember, there is a difference when somebody asks you for a shoulder MR versus somebody who wants an AC joint protocol, because the AC joint protocol is slightly different. That is more geared towards picking up injury to this particular part of the AC joint, the coracoclavicular. So clavicle, coracoid, there are two ligaments here. If you remember from your anatomy, the conoid and the trapezoid. So the conoid is more cylindrical and the trapezoid is more fan-shaped ligament. if somebody's got lots of high signal, the space is widened. This is typically what we get in AC joint injuries. So for that particular AC joint protocol, we would be slightly different because it's angled in a different way. So this is the coracoclavicular ligament, which is entirely normal in this case. There's no abnormal disruption. There's no high signal. There's no fluid. The space is still the same because if these ligaments are ruptured, the space gets widened, so this space increases. So I also look at that. And then, of course, I look at the muscles and the tendons. So we've looked at the AC joint. We now look at the muscles and the tendons. So what are the muscles? Let's look at the supraspinatus, which is the main muscle here. Now, remember, if you were at the talk, I said to you when I was doing the talk was to draw a line, say from the tip of the acromion to the tip of the coracoid process, and generally 1/3 of this muscle, which is the supraspinatus muscle, should be above this line. So if you draw a line, remove it. So if you go from outside towards the center of the joint, where you see this sort of picture, where you see the Y, if you were to draw a line between the top tip of the acromion and the coracoid, not half, 1/3 of the muscle should be above this line. As the muscle becomes atrophied, it starts to drop, and it keeps dropping, goes below the line, and ultimately it'll just sit here, which means the muscle is atrophied. And of course, if you were to do a T1, which we look at after this, you'll find out if there is fat atrophy in the muscle or not. So in other words, this is what I don't normally draw these lines, but I'm just drawing it for you because you just eyeball it and it's good enough if the muscle is atrophied or not. So look at the bulk of the muscle, nice and bulky. Draw a line here. Way more than half is above it, so that's pretty good. So I'm not worried about it. So just follow the muscle all the way towards the out, and you'll see the tendon coming in. Just keep following, just keep looking at this tendon first. We look at the other tendons in a second. You can see it's inserting onto, so remember the tendon inserts this, all of this is the supraspinatus tendon, 2.5 centimeters in length. You just want to make sure that there is no high signal in this tendon, because this is a very good sequence for picking up tears. You always confirm the tears on the two sequence. You look at them on the coronal. If you're suspicious, you again come back to the sagittal. If it's present on both, only then call it. If it's present on one, chances are that it's not a tear. So again, you can see this is nice and normal, nice and black. So this tells me that the supraspinatus tendon is normal. I also look above the supraspinatus muscle and tendon. Why? Because this is where the bursa is, the subacromial subdeltoid bursa. So if you see fluid here under the acromion, but above the supraspinatus tendon, that's in the subacromial subdeltoid bursa. So clearly in this particular patient, there's no fluid there. So that's one thing I've noticed. Now let's look at the other. This is the infraspinatus tendon, same sort of thing, quite big tendon, but when it comes close to its attachment, you can see there's no high signal, nice and black as we would expect. The teres minor is here. You can see the tendon in the muscle. So again, that looks normal. Go to the front, you'll see the subscapularis. And here you can see the fluid in the subscapular bursa, the same thing that we are looking at. This is the subscapularis. What is this structure, this black band? Aisha, what do you think this structure is?
The biceps femoris tendon?
The biceps femoris tendon. That's somewhere in the knee, if I remember correctly. The biceps femoris?
No, sir, biceps tendon. Sorry. I just wanted to say biceps.
The biceps tendon. So the biceps tendon, let's find out where the biceps tendon is. So the biceps tendon is here. So remember the supraspinatus, subscapularis, what sits in between the two? The rotator cuff interval. And what runs through it? The biceps tendon. So that's your biceps tendon. So what I'm asking you is, what is this? Any other ideas, guys? The rest of the 10.
Teres major?
Which major?
Teres major?
Teres major, the lady between the two ladies. Latissimus dorsi surrounded by two majors. So they have to be somewhere way down here. So teres major is somewhere here. Because remember, it attaches to the humeral shaft, not attaches to the tuberosity. So this is the middle glenohumeral ligament, the MGL, as you might have heard of. Remember, this is an intra-articular ligament because we're actually inside the joint here. Subscapularis is outside. This is inside the joint. So this is the middle glenohumeral. It runs parallel, but deep to the subscapularis. And the same goes on the axial. Sometimes if there is a little bit of fluid in the joint, you can actually see this ligament. This is the middle glenohumeral ligament. This is the superior glenohumeral ligament under the coracoid process. These ligaments we normally see on the MR arthrogram, but sometimes you can see them without the arthrogram. You just need to know where they are. So you can actually see the superior glenohumeral ligament, the middle glenohumeral ligament, and if you look further, this sort of whale-shaped gray structure is the inferior glenohumeral ligament. So you can actually see these ligaments. There's a little bit of fluid in the joint. You can actually see these ligaments. But of course, these are the ligaments that I would normally look for when I do the MR arthrogram. But sometimes you see them. This was just, by the way, this was just a tease question because it was there. And I just wanted to see if you knew your anatomy, which clearly you girls don't know and boys don't know your anatomy because teres major is way on the other side, somewhere here. This, by the way, is the inferior, the circumflex humeral vessels circumnavigating the humerus. Okay, so on the sagittal, what we've done is we've looked at the AC joint, we've looked at the acromial morphology, we've looked at the coracoacromial ligament, then we looked at the muscles and the tendons. So I looked at all these muscles and I looked at the tendons. So I've so far looked at the supraspinatus, the infraspinatus, and the subscapularis. And now we look at the biceps tendon, your tendon, Aisha. Now remember, biceps has got two heads here. This has got the long head and the short head. The long head is the one which is the one that we've been looking at so far, which arises from within the joint. And then if you look here, this black structure is the biceps tendon. If I make it an arrow, if I can, I don't know. But this is the biceps tendon, the longer biceps. So keep looking at this tendon. It's coming out here. Keep looking. It's coming out. It's coming out. This is the rotator cuff interval because this is the supraspinatus. That's the subscapularis. In between sits the longer biceps. It's still coming out. Still coming out there. See, this is where it is. So that is the longer biceps tendon. This is part of the longer biceps tendon. Then it starts to turn. And when it turns, it heads inside the joint then. This is intra-articular. And then it attaches at the top of the glenoid. So that is the long head. The short head actually arises from the tip of the coracoid process. It's an extra-articular tendon because remember what are the two things which come off from the tip of the coracoid process? The coracobrachialis and the short head of biceps. It's all about anatomy. So you see this is part of the coracobrachialis and the short head of biceps. This tendon, which if you follow a black tendon to the tip, is the short head of biceps. The short head and the long head come together in the arm and they'll form the biceps muscle itself. So the biceps muscle and the big bulk of your muscle that you see in your arm is actually formed by the short head and the long head. The long head is the intra and extra articular, and the short head is just arising from the tip of the coracoid process. So you always look at these muscles and these tendons, and they come together in the arm to form the biceps. So we've looked at what? We've looked at all the important tendons in the shoulder on the sagittal. Any questions on the sagittal? No questions?
Axial sequences.
Axial, yes. Coronal, no. So let's
Okay.
go back to the axial. So let's see if we can see anything. So this is the axial. And what you see here is this black band is the middle glenohumeral ligament. That's the same ligament that I just showed you on the sagittal. It runs parallel to the subscapularis on the deep surface. If you see a black line, that's the glove. But when I show you an arthrogram, you'd be able to see it beautifully. This is the middle glenohumeral ligament. The superior glenohumeral ligament is actually running here, this is the biceps. That's probably part of the superior glenohumeral ligament. Remember, there are two black structures. The longer one is the biceps. The shorter one is the superior glenohumeral ligament, and it runs parallel. The way to diagnose that is to actually pick that is that it runs almost in the same plane as the coracoid process. So if you see a black structure running in the same plane parallel to the coracoid process, that is the superior glenohumeral ligament, which is this thing. The inferior glenohumeral ligament is here, but you don't actually see them because it's like a curtain. It's got multiple bands. It's got the front band, the back band, the middle bands. These are vertical bands, which I'll show you when I show you the arthrogram. But we call them the anterior and the posterior inferior glenohumeral ligaments. But it's like a little curtain which has got multiple bands. So yes, you can see them, especially if somebody's got fluid in the joint, then you can see them very nicely. Okay, so let's look at the last sequence, which is the T1 weighted sequence. Now, in this particular patient, we've done a coronal T1 weighted sequence. You could do a sagittal T1 weighted sequence, but we've done a coronal sequence. And the whole idea is to look at two things. Number one, to look at the marrow. How does it look? It looks bright, which means it's fatty. Sometimes you can pick up metastases. Sometimes you can pick up myeloma lesions, which are low signal lesions on the T1. Remember, there's a good contrast because of fatty marrow. So you always look at the marrow. You don't just look at the humeral marrow. You look at the glenoid marrow. You look at the clavicle marrow. Just make sure you look at all the marrow. So one thing the T1 would tell you is the marrow normal or not? And if you see gray signal, so here you see gray signal, is that normal or abnormal?
Normal, sir.
Okay, so a little bit of normal because this is still a little bit of residual red marrow change. So remember, most of the marrow here has become fatty. So a little bit of this gray is the residual patchy red marrow change, which is still there. How do you know if the lesion is abnormal? So what you do is you've got to compare it with the muscles. If the lesion that you see in the marrow is less or more black or less low signal compared to the muscle, it is definitely abnormal. So use muscle as a criteria. If they're the same as muscle, ignore them. If they're brighter than the muscle, ignore them. If they're less than muscle, call them, because that means there's a problem. So that's your internal reference criteria to pick up abnormal marrow signal lesions. So that's how we look at the marrow. Of course, the whole idea, the second thing is to look at the muscles, and you see most of the muscles are gray except for a little bit of streak of fat in the middle of the supraspinatus. So that means there's a bit of fatty change happening in the supraspinatus muscle. Not much, mild, I would say grade 1. We'll assess the grading in a second, but primarily just very mild fatty change. This you'll only pick up on T1 weighted sequence. You won't pick up on the T2 weighted sequences. You won't pick up on ultrasound. You won't pick up on anything else. So this is a very good sequence to pick that up. So you look at all the muscles. You may see fatty atrophy of the infraspinatus in conditions like Parsonage-Turner syndrome. You look at the teres minor. Again, remember the axillary nerve, which is running here in the neurovascular. If that gets compromised, the infraspinatus and the teres minor and the supraspinatus may become neurogenic, may show neurogenic muscle edema initially, and then it becomes fatty. And of course, you always look at the subscapularis as well. So you'll get an idea as to whether there's fatty change. And that's pretty much it. That's all we use the coronal sequence or a T1 weighted sequence to look at the marrow and look at the muscles. That's all we need. And of course, if somebody's got a lipoma, you will pick it up on the T1 weighted sequence, because if you do a FAT-SAT sequence, you won't see it. So that's all we need to really look at when we are doing a shoulder. It's not that difficult. These are the only sequences which you will be looking at, and these are the only things that you would be expected to pick up. And once you pick up these things, then you start formulating your report. And of course, you mention all of these things in the report. You don't always say positive things. Sometimes you add negative things as well. So important negative. So if there is no fat atrophy, I would say the muscle bulk is looking good and there's no obvious fat atrophy. It's an important negative, but you mention it in your report, because then the surgeons know that you've been looking at the muscles. Because what happens if somebody's got fat atrophy and a rotator cuff tear? When you repair the tear, the recovery is not going to be as they would expect normally to be, because of the simple reason the muscle is already atrophied. So no matter what physiotherapy you do, it may not pick up. So the recovery is usually bad. So that's why if there's lots of fatty atrophy of the muscle, the surgeons may not do a rotator cuff repair, because they know the results are going to be bad. So that's how you actually report a shoulder MR. Any questions?
I will ask them to ask any question if they have.
Any questions before I go back to my presentation? What does that skull mean, Shakila? In your chat. Is that good or bad? I assume it's good. I assume it's good. So let's carry on now, go back to our presentation. I'm going to show you a few other things in the presentation. Then we come back to cases. And the cases, again, we'll look at the sequence in the same sequence as I've just actually told you. So we'll see if we can actually pick up pathology. Now, you guys are all muted. Is that right, Asha? Are these guys all muted?
Sir, I have not muted them. They can unmute themselves at any time.
If we were to ask questions, then I would suggest that feel free to participate, because we don't want to ask all the questions to Aisha. We just want to make sure that, if you've got opinion, you just mention it. It's an informal session, so I'm not doing a viva, so it's absolutely fine. You can be as foolish as you want to be. It'll just go down in the recording badly, but otherwise, it'll be fine. So I'm going to go back to my presentation, which was here, and we'll share the presentation now. So let's see what we can show you. Okay, and then we come back to the cases. Okay, so the important thing is, can you see the slide, by the way?
Yes, sir, I can see.
Okay, so the shoulder stability, which is really important, depends on a number of factors. There are the static factors and there are the dynamic factors. Now, what do we mean by static and dynamics? So it's straightforward. Static means the internal structures of the glenohumeral joint. What are the internal important structures? You've already seen them. The labrum, the glenohumeral ligaments. These are the static structures which everybody's got pretty much to the same degree. So they always are there. They will hold the shoulder stable. Dynamic factors are the structures outside. So in other words, things like rotator cuff tendons, the scapula, which is attached to the shoulder by the scapulothoracic muscles. So these are the extrinsic factors or the dynamic factors, because remember, these move all the time. So the stability is dependent on both the internal factors, which are static, and the outside factors, which are more dynamic. Okay, so let's look at the important things. When you be looking at the shoulder, these are the only diagnoses you'll come across. You'll be coming across rotator cuff tears. You'll be coming across impingement. You will be coming across calcification. You'll be coming across partial tears, full thickness tears. So that's pretty much it, really. Not much else you're going to see. So impingements tend to be, typical presentation of people coming to you and saying, "Oh, I've got shoulder pain," especially when I raise it above the head or I try to reach back towards my back. That's when I get the pain. This is the typical presentation. Usually, they're middle-aged patients, so middle-aged males, females. And there are a number of causes. There are certain primary causes, there are certain secondary causes. So the primary causes are, remember the coracoacromial ligament I was telling you when you were looking at that black line? So if that gets thickened, it presses on the underlying bursa and the underlying tendon, and people get impingement. If somebody's got an osteochromiale that we discussed about, that can also cause the impingement. And remember, the third thing that we discussed, we've actually looked at all of these causes, is the shape of the acromion. So if you've got these three factors, these are the main reasons why people get impingement. There are secondary causes, of course. Secondary causes are wear and tear in the shoulder joint. So, in the AC joints, if somebody got big osteophytes arising from the undersurface of the acromion, it'll cause impingement. So typically, this is the kind of, this is the coracoacromial ligament, this is the acromion, and this green thing is the bursa. So whenever there's anything which presses on the bursa, it causes the bursa to become thickened and ultimately inflamed and ultimately accumulate fluid. And that's the reason when people move it in certain direction, the shoulder, they tend to get pain. So that's called impingement. Can you actually diagnose impingement on the X-ray? You may get some idea. So in other words, you on the Y view, which is the important lateral view, you may be actually able to see the shape of the acromion. You may be able to see the spurs. So you will get some idea on the plain X-ray. So how, you know, the types of acromial morphology that we were discussing. Imagine this is the sagittal view. So type 1 is this. This is nice and flat. This is a type 1 morphology, which is the normal appearance. This is the type 2, where it forms a little hook, and that hook presses on the underlying bursa and the tendon and causes impingement. The third is the hook becomes even worse. So in other words, very prominent 90 degrees angle of the hook. And the fourth is the convex one, in which it's reversed, so it has a convexity, and again this can cause impingement. So the best ideal scenario is most of the people will have type 1 or 2. 1, they'll probably have no symptoms. Type 2, they'll probably have no symptoms as well. It's only when the hook becomes really prominent that they start to get impingement. This is the coronal acromial morphology. Remember, I told you when I mentioned in my report, I always look at the coronal. So it should normally be like this. In other words, it should be flat like that. But what happens if it slopes laterally? It'll press on the underlying bursa and the underlying tendon and cause impingement. So what sort of shape of the acromion do you think this is? On the coronal?
Type 1 flat.
So it's flat, it's a horizontal. Remember, the type 1 and type 2 and type 3 is based on the lateral view of the X-ray or the sagittal view of the MR. This is a coronal or an AP view equivalent to the coronal that we've been looking at. And here you want to just see, is it laterally sloping or is it not laterally sloping? So this is more horizontal as we would expect it to be. Is that right?
Yes, sir.
The only thing is there is a bit of an osteophyte here on the undersurface, and there's also some ossification on the undersurface, which may cause symptoms, but who knows? Okay. Ultrasound, very good for picking up rotator cuff problems, as you know, we discussed when we were back in Quetta, and I showed you some figures as well as to which is better. Actually, MR and ultrasound are pretty much the same. So if somebody asks you in a Viva, they've got the same sensitivity, pretty similar. Same sensitivity, same specificity for picking up partial and full thickness tears in the rotator cuff, provided, of course, you're trained. In other words, you regularly do ultrasound of the shoulders. And what we see normally is this is a transverse view of the rotator cuff. The tendon is slightly thickened. There's no hard and fast measurements that we normally do. We don't measure these tendons. It's just a visual look of how the tendons, remember, look bright on ultrasound. They're more echogenic because they're tightly compact structures. So on ultrasound, they would look bright. So if they get sort of, if you lose the distinction between the tendon and the muscle, then think about tendinopathy or tendinosis, because there should be a difference in the muscle and the tendon on ultrasound. If they look similar, that means there's a problem. So this is an MR scan of tendinopathy. So the reason we call it tendinopathy instead of tendinitis, as we used to call them in the past, is that there is inflammation. Itis means inflammation. So there is some inflammation when somebody gets, but it's actually not the main issue. The main issue is that it's repetitive injury. In other words, it's constant irritation, same repetitive injury, which causes these tendons to become traumatized. So they have these little micro tears. They also have, on top of that, some inflammation, and that's why they become abnormal. Now, why do I say that this tendon looks abnormal? And the reason for that is, if you look at the tendon, it's not only swollen, it is bright in signal. Now, tendons are never bright on the MR scan. No matter what sequence you do, they should always be black in color. In other words, hypo intense. So if you see the tendon to be bright, it is abnormal. So if it's diffusely bright, you call it tendinopathy. If it's focal, you think about tears. Okay, so that's the difference. Now, one important difference between tears and tendinopathy is that the signal, can you see, is bright, but it's not as bright as fluid in the joint. And that is what typically happens in tendinopathy. If it's as bright as fluid in the joint, you'll always have a little bit of fluid somewhere to compare it with, then that is a tear. So look at the brightness of the signal. If it's really white, like this, then it's a tear. If it's sort of gray-white, that means it's tendinopathy. Again, this is the the coronal, and what you see here is the muscle, and look at the tendon. It's all nice and bright. And this brightness is that because the tendon is diffusely edematous, not the same signal as fluid here. I would call it tendinopathy. Of course, if you look at the lateral end of the clavicle, can you see a big osteophyte? This would be pressing on the underlying bursa and cause impingement. Look at the big osteophyte on the T1 where it's sequenced. Remember, T1 is very good for looking at bones and muscles. Bones, you can see why it's important. You may not appreciate the osteophyte here, but you can easily pick up the osteophyte here because it's marrow, it's bright. That's why it's easy to pick up. This is the os acromiale. Remember, I was telling you the axial sequence is really important. If I showed you the sagittal sequence, you won't pick it up. I mean, some of bright people in you might pick it up, but actually most of you will not pick it up unless you look at this sequence. So this triangular bone is the os acromiale. This is an unfused apophysis between the accessory ossicle and the acromion. This is the lateral end of the clavicle, and this is the reason why this patient is getting impingement. So that's the importance of the axial view, as I was telling you. So we are showing you everything in the reverse order. I've just shown you first what we would look at when we were reporting these MR scans, and then I'm showing you some examples as what to expect, how these things look. Okay, so cuff tear, one of the common reasons why people get shoulder pain is partial or full thickness tear. And these tears, remember I told you, can also mimic slap tears. Important thing for you to tell the surgeon is the tear more than 50% of the thickness of the tendon? Because if it is, it means they may need surgical repair. If it's less than that, then most of the time the treatment is injections and physiotherapy. So in other words, conservative management. If you think there is a bit of overload, just let me know and I'll bring the tempo down. We are beyond 1 hour and 10 minutes already. So probably another 20 minutes and then we'll call it a day. So this is what a partial thickness tear would look like. So this is a coronal orientation. This green thing is the subacromial subdeltoid bursa. This is the supraspinatus tendon. That's the greater tuberosity. This is the footplate I was telling you about, where the surgeons may not be able to see the tear, especially if it's here. If it's here, this is called the articular surface. So when the surgeons go in, they're able to see this very nicely because this is the articular surface, but they're not able to see this because it's attaching to the bone. That's the footplate. So this is a partial thickness articular surface tear. This is a partial thickness bursal surface tear. Again, you'd be able to pick that up on imaging, not on arthroscopy because it's on the superficial surface. And this is the rim-ren tear or the intrasubstance tears that the surgeons won't be able to pick up, which you will be able to pick up. All of these are partial tears. They're different locations, one on the articular surface, one on the non-articular surface, one in the middle. Let's look at the examples. So what you see here is an abnormal signal here. Can you see that? Which is pretty much the same signal. It's quite focal, but pretty much the same signal to the fluid. So I would call it a partial thickness articular surface tear, which is equivalent to this here, corresponding to this here. There's also a bit of muscle tendon junction edema, which is fine. Look at another articular surface tear. Can you see that? The signal is very similar to fluid elsewhere. So this is an articular surface. The important thing is, where is it? This is the foot plate. This is the articular surface of the tendon. This is the front. This is the back. This is the middle. So when I'm reporting this, I would say this is a partial thickness articular surface tear of the supraspinatus tendon involving the central slip. So I've told them which tendon it is. I've told them which part of the tendon it is. Is it at the front? Is it in the middle? Is it at the back? I've said the central slip, which means in the middle. And then I'll say, and I've also said to them, it's a partial thickness tear. And then I'll say, how much does it measure? So it measures from here to here. This is called the medial lateral extent, and this is called the AP extent. Now, if I was to ask you, how much do you think the thickness of the tendon is involved, what would you say?
I think it's more than 50% of the tendon thickness.
Correct. So it's more than 50%. In other words, it's quite significant, although it's a small tear, but it's quite a significant tear. So it's more than 50% of the thickness of the tendon which is involved here. So this is important because the surgeons may want to repair, especially if it's a young person. Okay, what about this? This is an intrasubstance tear. So in other words, if you look at the articular surface, it's nice and intact, but all the brightness seems to be heading right in the middle of the tendon. In other words, right here. So this is a partial thickness intrasubstance. We also call it a delaminating tear. So it's a delaminating tear of the posterior. Now this is the front, this is the middle, this is more towards the back, right? So it's more the posterior, almost getting close to where the infraspinatus is. So this is and sometimes it can actually involve the infraspinatus as well. So it's a partial thickness intrasubstance tear. On ultrasound, it's a similar appearance. Tendons are bright, but if you see black areas, so see the black area here, that's the tear. See the black area here, that's the tear. That's how it looks on the ultrasound. But of course, we are looking at the MR today. This is the opposite. This is the bursal surface. You see the top here? The tear is not here, it's at the top. So that's the bursal. And this is an intrasubstance. That's how it looks on ultrasound. It's all just within the tendon. As I was saying, if you look at the figures, not much of a difference. Nobody does an MR arthrogram for picking up tears, but not a huge amount of difference between the accuracy of MR versus. So what I would mention in my report is this. What is the type of tear? In other words, it's a partial thickness or a full thickness. Where is it? Anterior, middle, and posterior. What is the size? AP and medial lateral. And what is the depth? If you mention all of these things, you're home and dry, because that's all you need to tell them. What about the full thickness tears? Typically, the age group is higher. In other words, beyond middle age, 40 years and above. Most of the patients tend to be that age group. And what they present is pain. And of course, they present with loss of strength. That's typically what they present with. Sometimes you can get it in young patients, but it's not very common to get full thickness tears in young patients. So this, you can on the plain X-ray tell that the patient has got a full thickness tear. And why? Because look at the loss of the acromiohumeral distance. In other words, the distance between the acromion and the humerus is gone. So this can only happen if there is no tendon in between. In other words, it's chronically torn tendon. Look at this MR scan of the same patient. There is nothing. There should be a black tendon coming and inserting here. All you see is just a little bit of bright fluid because there's nothing in between. All you see is the bright fluid. There's nothing in between which suggests tendon. Remember the scan we were looking at? The tendons are black in color, like this, the infraspinatus. Where is the supraspinatus? It's not there because it's completely torn. And what happens is, as it tears, it starts to retract. So then you have to tell the surgeon, where is the retracted tendon sitting at? What do you think? Where do you think the retracted tendon is sitting here on the coronal, on this particular? Above the glenoid. See, this is where it's actually sitting. That's part of the torn retracted tendon. This should have been here. So this is retracted. And it's the same for ultrasound. You'll see a same full thickness defect. Remember, the only thing that you need to remember is full thickness tears can be partial width full thickness tears or full width full thickness tears. What do I mean by that? Remember, the tendon inserts onto the tuberosity. You can have a full thickness tear going up and down, just involving part of the tendon, or you can have a full thickness tear going up and down involving the entire tendon. So if it involves the entire tendon, you call it full thickness, full width. If it involves part of the tendon, you call it partial width, full thickness. So that's as simple as that. So it's just a terminology that you need to know. The other important thing is sometimes when these people have tears or chronic tears, you form cysts in the muscle. So can you see a big cyst here? So if you see a big cyst sitting in the muscle, usually there's an underlying tear. So here you see a big supraspinatus cyst intramuscular, and that is only because the fluid is coming from the tear, getting accumulated into the muscle. So if you see a big cyst in the muscle, the rule is you've got an underlying tear. Okay, so again, no difference between MR and ultrasound in terms of sensitivity and accuracy for picking up full thickness tears. Okay, so So this is the classification I was telling you about the muscle atrophy. So this is the sagittal view of the MR scan. So if you draw a line, more than 1/3 is above, that's normal. When you start getting streaks of fat within the muscle, you call it grade 1. When it's less than 50%, in other words, if you draw a line, still some part of it is above it, but the supraspinatus fossa itself, most of it is muscle, less is fat, you call it grade 2. When you see more fat in the fossa, less muscle, you call it grade 3. And when you see streaks and complete replacement of the fossa with more fat and very little muscle, you call it grade 4. So you can read, this is called Gitalia's classification. You can read it if you want to, but it's quite straightforward. In other words, just visually say if there is or isn't fatty atrophy of the muscle. Just warn the surgeons if there is or isn't. Okay, frozen shoulder. I don't think we need to go too much. You've already seen a case of frozen shoulder, but remember it's a clinical diagnosis. Right, let's look at a couple of cases in the last 10 minutes. Any questions so far? No.
Sir,
No.
I need to ask a question regarding the partial, the partial width full thickness tear. I didn't understand that thing.
Okay, so imagine, can you see my shoulder? So the supraspinatus is coming like a band. See, it inserts like this. Imagine you've got a full thickness tear. Full thickness means it involves the entire top to bottom thickness of the tendon. Now, this thickness of the tendon, remember in the partial thickness, we said more than 50% is important. So here it's 100%. In other words, from the top to the bottom, the whole of the tendon is torn. Now, this whole of the tendon can be torn either centrally or at the front or at the back or all of it. What happens if it's torn all of it? It'll pull back. It'll be retracted. But if it's partial width, only part of it is torn. There's still fibers intact on either side. That's why we call it the partial width full thickness. Then the tendon does not retract, it stays where it is because there's still fibers holding it. So that's the difference between a partial width full thickness versus a full width full thickness tear. In other words, if you were to say somebody's got a complete supraspinatus tear, it means the tendon is completely torn and retracted away from the humeral head. But if you think that there is a tear all the way top and bottom, but it hasn't retracted, it means it's a partial width full thickness. Does that make it clear?
Yes, sir. Thank you.
Good. Okay. So let's just look at a few cases. Do you want to look at a few cases?
Sure, sir.
One thing that I haven't touched on, and actually I will show you now, is this. So in other words, if I share this screen, okay. So I'm going to show you a coronal sequence, and the reason I'm going to show you this is that I haven't mentioned this pathology. So here we are at the front of the shoulder, and the reason why I say we are at the front is the coracoid process. So this is the front humerus, and as we go back, what you see is very difficult to pick up, but actually it's there. Can you see these black areas?
Yes, sir.
These black areas are calcifications. So remember, calcification is black. So is the tendon. So it's difficult to pick up on MR scan. But if you develop your eye, you can actually pick up calcification very nicely. So the tendons are black, but this sort of more discrete black areas is calcification. So this is classical calcific tendinopathy. You get lots of calcification, then as a result of that, you get irritation of the bursa, and this is typically what you see in calcific tendinopathy. Now let's go back. So I just wanted to show you that. This is how it looks on the T1 where it's sequenced. So this is the tendon, which is black in color, but as you go back, you see further black areas. You can actually make out these black areas. So these are calcific foci in the tendon. So if we were to look at this patient, as we would normally, we'll start with the axial sequence, right? So on the axial sequence, remember, what did I say to you? I said to you, look at the alignment, look at the AC joint. If you're starting at the top, make sure that there is no os acromiale. Look at the articular cartilage. Look at the glenoid labrum. Look for any joint effusion. Look at the joint capsule. There's nothing of that in this case. So the joint may show a little bit of chondral wear and tear, nothing major. There's no joint effusion. There's no abnormal signal in relation to the labrum. The orientation is well maintained. How does the shape of the humeral head looks like? So if you look at the top, nice and black, except for this flattened sort of black area. Remember, this is calcification which has gone into the bone. So it's eroded into the bone. So this is the only thing that we picked up. This is the calcification. This is the calcification. So these are calcific foci in the tendon. But otherwise, the things that we looked at look pretty unremarkable. So there's no glenohumeral wear and tear. There's no joint fusion. There's no capsulitis. There's no os acromiale. The visualized tendons look okay. Why? Because the subscapularis looks okay. The infraspinatus is mildly edematous. Can you see the edema here? And then, of course, we've already picked up areas of calcification within the tendon. So even on the axial, we've come to the conclusion that this patient has got tendinopathy because there's bright signal in the tendon, which is the supraspinatus and infraspinatus. And we know that there are black areas, which is calcification. So we know even from the start that this patient has got calcific tendinopathy. What about the biceps tendon? Looks nice and normal. Follow the biceps tendon. There's a little bit of fluid, which I'm not too worried about. Follow it up, see where it goes. It goes here. So that's the long biceps tendon. So I'm happy with that. So in other words, we've looked at the axials and we've come to the conclusion that there's not much going on except for calcific tendinopathy and, of course, bursitis. Bursitis is the fluid in the bursa. Remember, there's no tendon here. We're way below the humeral head or towards the bottom of the humeral head. So all you see is just bright fluid, which is in the bursa. The second sequence that I looked at normally would be the coronal sequence. And what are the things I'm looking at on the coronal sequence? Same things as I go from the front to back. You see that there is bursitis. The bursa is a big cap sitting on the shoulder like my hand. So it runs from the medial to the lateral and front to back. Remember all of this. If you put your hand on the shoulder, this is your bursa. So the bursa is a big structure. It covers the front, the medial, the lateral, the front, and the back. So it covers the whole of this. So this is the bursitis with calcification. The muscle bulk looks okay. We've looked at the subscapularis tendon here at the front. Doesn't look bad. This is the short head of biceps tendon. Doesn't look bad. The biceps long head we know looks pretty good here. Keep going back. We come across the AC joint. What is the shape of the acromion here?
So this is a bit slanting downwards, maybe type 2.
So this is the, you don't call it type 2, just say laterally sloping. So this is the laterally sloping acromion. And of course, there's a bit of capsular hypertrophy or degenerative change at the AC joint. Not much, just a little bit of brightness here compared to the bottom. And of course, there's the underlying bursitis as a result of that, laterally sloping. Infraspinatus tendon looks okay. The muscle bulk generally looks okay. So we've looked at the axial, we've looked at the coronal. Let's look at the sagittal. Sagittal, we start right at the end, and the things that you start seeing are these black foci, which is calcification, and the brightness, which is the bursitis. Remember, the bursa goes on the side. So we're starting at the side and coming centrally. So this is the right of the, this is the first or second slice at the side. So you see bursitis, you see this calcification, you see calcification, you see calcification. So remember, the supraspinatus tendon should have been nice and black. So you see the tendon, but there are black areas even further blacker than the tendon, which is calcification. This is the bursa I was telling you about. So if somebody's got bursitis, this is typically what it looks like. Looks like fluid between the acromion and the tendon. This is the coracoacromial ligament, the black line. See there? See that? It looks a bit thickened here, so it may well be impinging. We already know he's got a laterally sloping acromion, so he may well have an impingement, because remember the previous patient that I showed you, you could barely see the black line. Here you can actually see the black line nicely, which means it's a bit thickened. What about the subscap? Looks okay. What about the infraspinatus? Looks okay. Follow the tendon right down to its insertion. Maybe a little bit of edema at the infraspinatus. So I would report this as infraspinatus insertional tendinopathy. Subscapularis looks okay. The long-headed biceps tendon, where is it? Sitting right here. Follow it. Starts here from the glenoid. Just follow it here. Follow it. Follow it. Follow it. It's coming out. Keep going. Keep going. It's coming out here. Keep going. There it is. So it's come out. So that's pretty okay. Not much going on. What about the shape of the acromion here now? Which type is it? Ideas? Go on.
It's type 2.
Type 2 is more like this. So if you actually follow it, it's almost flat here. So I would say type 1. And this is where, if it was type 2, it'll go like this. So it'll head like this. So I would say it's a type 1, but there's a bit of capsular edema. Okay, so, and what about the muscle bulk? Looks okay? All three muscles,
Yes,
1, 2, and 3, they all look pretty good. Nothing in the axilla. So what are the things that we still need to look at? The marrow and the muscle bulk. Look at the blackness here. These are the calcific foci. How does the marrow look? Not bad. These are residual marrow patches, the red marrow patches. Looks pretty good. No fat atrophy. Okay. So we pretty much followed the same things that we discussed quickly this time. And in about, so the next case that I'm going to show you will do the same. So in about 3 minutes or 4 minutes, you can actually come to a nice diagnosis, how and what are the things you're looking at when you're doing the shoulder. So always follow the same sequence. Look at one more case. Let's see what case I'm going to show you. Okay, so we are going, this moves a little bit. So
there's a question from Dr. Sadia Saif.
Yes, go on.
That she was asking, what was these calcification diagnosis? So we just have to mention it in our report.
Yeah, it's called calcific tendinopathy. So calcification is a wear and tear phenomena. There are different kinds of calcifications that people get in the tendons. Some develop over a period of time, repetitive injury, and these are usually solid areas of calcification. These are solid chunks of calcification, and they stay there without causing any symptoms, and sometimes they get irritated and then they will cause symptoms. And then there's another kind of calcification, which is the liquid calcification. That liquid calcification is called acute calcific tendinopathy, and that is exquisitely painful. So the moment the patient walks into the room, you can tell that this patient has got calcification, because they are miserable. They can't even talk to you. They're holding their arm, and the history is very short. The pain has come up suddenly last night or day before yesterday, and it's severe. They can't even move the shoulder. So that is liquid calcification. So liquid calcification will not look like this. You will not see it on the MR scan. You'll only see it on the ultrasound. Even on the plain X-ray, you will not see it. So if you do an ultrasound, you'd actually see a nice blob of liquid calcification sitting within the tendon. And all you have to do is put lots of local anesthetic around it, stick a needle in and suck it out, and the pain goes away immediately. So you can get rid of the symptoms straight away. And they're so grateful, because they've been in this exquisite pain for the last 2 or 3 days. And suddenly you stick a needle in, and you suck it out, and there's no pain. So liquid calcification, you can do something about it. So that's why calcification is important. Okay. So let's look at this next case. We are almost coming to an end now. So I will share this, and we will do the same thing. So we'll start with the axial sequence. So when we start with the axial sequence, we start right at the top first, and then we start going down to the bottom. So we look at this first. What do you see? The AC joint, does it look normal, abnormal? looks okay. There's a bit of fluid in the joint. There's a little bit of marrow edema of the acromion. Clavicle looks okay, but there's no os acromiale. Okay, keep going down. What does the shape of the humeral head looks like? Looks okay. There's no significant flattening. There may be a little bit of flattening, but not much. It's primarily a round joint. There's no obvious dislocation or subluxation. The humeral head is slightly subluxed back. So if you look at the posterior margin here and compare that to the humeral, so if I was reporting it, I would probably say slightly subluxed back. But remember, this humeral head is internally rotated. Why I say that is this is the intertubercular groove. Normally the groove is here somewhere, but imagine if the patient rotates the humeral head internally, then this comes forward, so it starts looking this way. So it's this bit of subluxation is probably because the fact that the patient is holding the palm downwards. In other words, instead of when we lie them in the scanner, we ask them to keep their palm upwards. But if you do this, then the humeral head comes like that. So that may be the reason why it looks as if it's subluxed. Okay, what are we looking at? We're looking at the cartilage here. Cartilage looks okay, maybe, I mean, not too bad, but there's a bit of fluid in the joint, the glenohumeral joint, right? Slightly more than we would expect. It's lying in the posterior recess. What about the labrum? So the posterior labrum is, you can still see a bit of triangle, There's no abnormal high signal. There is no paralabral cyst. You can't really see much of posterior labrum. So I would normally say this is probably degenerate rather than call it a tear. And as we go further down, you see there's glenohumeral joint effusion, right? So there's more fluid in the joint. What about the joint capsule? Does it look a bit thickened? It does look a bit thickened. There's even fluid coming here. So remember, if there's fluid in the joint, it can be in the inferior axillary recess, both at the front and the back. So I would say the capsule is a bit thickened, definitely abnormal, doesn't look like a normal capsule. There's definitely fluid in the joint. What about the tendons? Let's look at the infraspinatus. Is this a normal tendon?
The signals are a bit heterogeneous in it.
In other words, they're more bright than what we would expect.
Yes.
So the tendons are black. So you can see that this tendon is bright, which means tendinopathy. And there is also fluid here. Where would this fluid be?
The subscapular nodes in the bursa.
It's at the back. So it's in the bursa. Remember, the subacromial subdeltoid bursa goes front to back, medial to lateral. So you're actually cutting across the subacromial subdeltoid bursa. When we look at the other sequences, you will certainly see them more beautifully. But I can tell you now that there is fluid in the bursa. What about the subscap? Okay, so the subscapularis tendon doesn't look normal to me. Why? Because it has a wavy contour. You see, normally it should be a nice black straight line. What you see is this. Whenever you see a wavy contour, you should start worrying that there is a tear of the subscap. It may not be a full thickness tear. Remember, the tendon may be torn at the top. The inferior part may still be okay. This is the bottom of the tendon. Again, looks pretty abnormal because it's gray in color. It should have been nice and black like this. Lots of fluid in the subscapular recess, which shouldn't be there. So that means there's definitely something abnormal, even on this first sequence, abnormal in the subscapularis tendon, abnormal in the infraspinatus tendon. This we suspect is tendinopathy because we can still see the tendon in its continuity. This we think may be a partial tear. And what about the elongated biceps tendon? Where is it? Can you see a little tendon in the groove? You don't actually. You're struggling. Where is the tendon gone? Which means that this may well be torn. This groove is empty.
Just fluid. It's just fluid filling the
fluid. That is right.
groove.
So where's the tendon? Which means it's got to be torn, either retracted at the top or retracted at the bottom. So in other words, on this sequence, we've become suspicious about 3 tendons. We know there is bursitis. We know there is glenohumeral joint effusion. We think the inferior joint capsule is abnormal, even on a single sequence. And let's look at and of course, you look at the cortical irregularity of the tuberosity. It's quite irregular. Normally, it should be nice and smooth. Again, that goes with tears. If you get irregularity, generally, that means there's a tear. And of course, we know there's no os acromiale. We know there's a little bit of fluid in the joint. The deltoid muscle looks okay. Nothing in the axilla that I can see. No lymph nodes, no mass. part of the ribs that we can see, and the intercostal muscles look okay. Okay, so let's go to the next sequence. What sequence should we go to the next?
The coronal?
The coronal. So this is the coronal sequence. So we'll start right at the front, which is this here. So right at the front, what we see is fluid in the subscapular recess, which is the same. You won't be able to see, you can see the tendon, but you'll see it better on the axial, axial and sagittal, the subscap. The supraspinatus is the one that we want to look at. Where's the supraspinatus tendon?
So it's not visible. It's kind of, the supraspinatus seems retracted.
It's completely torn, and it's retracted sitting here. So this is the supraspinatus muscle. This is the tendon. It's sitting here. It should have been coming and inserting here. That's why the humeral head has gone up. That's why there is no space between the acromion and the humerus. And that's why you see fluid, which is in this subacromial subdeltoid bursa. So even without looking at the T1 where it's sequenced, would you suspect that there is diffuse fatty atrophy of the supraspinatus or not?
So it seems atrophied.
Very
just by the size of it.
What is this black thing? This is the fat. This is the fat suppressed sequence. So this is all fat in the supraspinatus fossa. So when we do the axial on the sagittal, you'll see how much of fossa is replaced by fat and how much is muscle in there. Already you can see it's half and half, which means there is definitely more than grade 2 fatty atrophy of the supraspinatus without looking at even the sagittal T1. So here you can confirm that there is complete tear of the supraspinatus tendon. In other words, full thickness tear, which is retracted above the humeral head. There is gross fatty atrophy of the supraspinatus muscle bulk. There's loss of the acromiohumeral space. You can confirm that there is inferior glenohumeral joint effusion. You can confirm that there is bursal fluid. Remember, this is the bursa on the outside. So you can confirm that there is subacromial subdeltoid bursitis. We look at the infraspinatus, which is at the back here, looks normal or abnormal?
It also has right signals.
Correct. So
it's attachment.
This is the subacromial subdeltoid bursa fluid, but this is abnormal signal within the tendon, which means at least tendinopathy. Look at the teres minor. Sorry?
Sorry, I guess someone opened the mic mistakenly.
Mistakenly opened the mic. Okay, this is the teres minor. This is the teres major. Look where the major is, Aisha. See? It's way down. This is the minor. So the infraspinatus is abnormal as well. What about the AC joint? Remember we said we looked at the AC joint. So what you see is a little bit of diastasis of the joint here, slightly widening of the space with a little bit of capsular edema, but no other abnormality that I can see. Okay, so on the coronal, you've confirmed all of these things. What do we look at now?
Sagittal?
Sagittal. Let's look at the sagittal. Okay, here is the sagittal. The first thing which tells you is if I was to draw a line, what would I see? How much of this is below?
So it's more than 50% atrophy of the supraspinatus muscle.
Correct. Most of the fossa is replaced by fat. This is the muscle. So that's significant fatty atrophy. In other words, if you were to repair this tendon, the results are going to be bad. Okay, so you won't see much. What about the subscapularis? Remember, we were worried about the subscapularis. We thought that there was a tear. So let's look at the subscapularis tendon. So this is the tendon. This is the bursal fluid, or in the subscapular bursa. Let's follow the tendon, see what it does. Keep looking at this tendon. This tendon has multipennate fibers. So you see 2 or 3 black bands, which is normal. Okay, so this is the torn subscapularis tendon. Because this is an abnormal contour. It should be nice and straight, inserting onto the lesser tuberosity. So if you follow the tendon, you can see part of the tendon is normal, part of the tendon is abnormal. There's high signal there. So I would call it at least a partial thickness tear of the subscapularis insertion, significant partial thickness tear. It probably is a full thickness tear, and the reason why I say it's a full thickness tear is because we couldn't see the biceps tendon. So if you don't see the biceps tendon, there can only be 2 reasons. Either the tendon is torn here, or the tendon is torn with the biceps tendon pulled back into the joint. Now, the biceps tendon will only go back into the joint if you've torn the subscapularis. If the subscapularis is intact, the biceps tendon cannot go back into the joint. So you have to tear the subscapularis for it to go back into the joint. So because we can't see the biceps tendon, we know the subscapula is torn as well. So this patient has got major problems with the cuff. He's completely torn the supraspinatus, he's completely torn the subscapularis, he's completely torn the long head biceps tendon, which is retracted probably into the joint somewhere, which we can't see. And the inferior part, if I go peripherally, see if you can see the bottom of the tendon. It's probably somewhere here. That's the other bit of the tendon. Remember, this is the biceps muscle. So the other bit of the tendon. So there should have been a tendon going all the way up here and then into the joint, which you don't see, which is torn. So here, and what about the shape of the acromion? This is more like a type 2, sort of curving, probably at the border of type 1 and type 2, but you can call it type 2 because it's sort of curving like this. So this is a type 2 acromion with joint fluid, slight diastasis, a little bit of capsular edema. Infraspinatus, let's look at the infraspinatus. The muscle looks abnormal because it's the same fatty atrophy that you see in the supraspinatus, you see in the infraspinatus as well. Look at the subscap. It has got more muscle meat in it. Here, the two muscles look identical, which means that this is atrophied as well. So you follow it peripherally, see where it inserts. So you actually can see only bits of it, not completely. I can't really see a nice black tendon inserting here. So this patient has got rotator cuff arthropathy significant. What is the last thing that we want to look at? The T1 various sequence. Let's look at the muscles, see what they're doing. What is this muscle? Supraspinatus.
Supraspinatus.
How bad does it look? Completely atrophied. Where's the infraspinatus? Look at the muscle. It's all white rather than gray. It should have been a big gray muscle. This can only happen if the muscle is completely torn. Otherwise, you don't get fatty atrophy. So you see the difference between this muscle, and this muscle. This is all bright. This is gray. This is more gray. So this is a normal muscle. Teres minor here is probably normal. You can see it here. But this infraspinatus is abnormal. So is the supraspinatus. What about the subscap? If we come at the front, see if we can see the subscap. So again, the subscap probably looks a bit fatty. Difficult to say where it stops, but this is definitely, I think there is a bit of fat atrophy of the subscap as well. So this is subscap, then we have the scapular body, and then the infraspinatus. So this is the infraspinatus, which I was saying. So this is the other way. So this is the infraspinatus, which has got fatty atrophy. This is the subscapularis, which has fatty atrophy. And that's where the torn tendon was. And this is the supraspinatus. In other words, all three muscles are atrophied. Supraspinatus worse, then the subscapularis, and then the infraspinatus. So all three tendons are torn. So that's how you read a shoulder MR scan.
So I have a question regarding this study. As we saw in this case that the supraspinatus is completely torn. So, and you said that this acromion is type 1 or probably type 2. So I'm a bit confused because because the supraspinatus is torn, so the space between the humerus and acromion would automatically be reduced. As the space is reduced, then how can we identify the type easily?
So
because
the type
to me, it seems type 1.
It doesn't matter what type it is, because at the end of the day, okay, you're talking about the type is a constant feature. So that is congenitally with what you're born with. So the shape of the acromion is what you're born with. What else happens is the wear and tear. So in other words, this shape has got nothing to do with the fact that the patient has got a full thickness tear. The full thickness tear is a wear and tear phenomena. So that shape causes impingement, but people with type 3 will be normal. People with type 4 would have normal muscles. And here, it's probably a type 1 or a type 2, and you've got a full thickness tear. So that shape is important for impingement, not for tears. The tear is a phenomena which occurs irrespective of the shape of the acromion. Of course, it can predispose to wear and tear if you've got a downward pointing spur, but you can have a tear without abnormal morphology of the acromion. Do you get it?
Yes, sir. Yes.
Okay, any questions? Because we are going to stop now. So if there are no questions,
Asked too many questions.
anybody else who wants to ask a
Sorry.
question? Okay, great. I assume there are no questions. So excellent. Thank you very much. I promised that I'd give a session, so hopefully that will explain. At least it'll tell you what to look for when you are looking at a shoulder MR scan. That's the whole idea. I mean, as long as you can remember half of what I've told you,